Hello everyone. Today we are going to solve a problem-based question. First we will read the scenario and questions. Then we will try to find the clues and solve the questions together. The scenario is a 35-year-old office worker present with numbness and tingling in the lateral 3.5 fingers of the right hand. She also reports difficulty in holding small objects. On examination, there is weakness of thumb opposition, but sensation over the central and thinner side of the palm is preserved. The questions are: which nerve is being compressed in this condition? Second question is, why is there weakness in thumb opposition? And third one is, explain anatomically why the skin over the central and thinner side of the palm is not affected. So first we will find out the clues and then try to solve this question. Our first clue is office worker. Then second clue is numbness and tingling in the lateral 3.5 fingers. And third clue is difficulty holding small objects. Let's begin with the second clue, that is numbness and tingling in the lateral 3.5 of the fingers of the right hand, and that means the thumb, index finger, middle finger and half of the ring finger. This is an important clue because this area of the skin is supplied by the median nerve. So this specific distribution tells us that the problem involves with the median nerve. So where does the median nerve come from? The median nerve originates from the ventral rami of cervical 5 to thoracic 1 roots of the brachial plexus. Then it is formed by the medial union of medial and lateral cords, and then travel down in the arm, but it does not give any major branches there. Then the nerves enter in the forearm through the cubital fossa. In the forearm, it innervates most of the muscles of the anterior forearm. Those are the flexors, most of the flexors and the pronators. Then it passes through the carpal tunnel at the wrist and enter in the hand. So what is the carpal tunnel? It is an osteofibrous canal at the wrist, and its floor and sides are formed by the carpal bones, which create a concave arch, and the roof is formed by the strong band of connective tissue called flexor retinaculum. Inside the tunnel we find the median nerve and 9 tendons of the flexor muscles. Those are the tendons of flexor digitorum superficialis, flexor digitorum profundus and flexor pollicis longus. So any problem inside the tunnel can compress the median nerve. Now let's go back to the first clue. The patient is an office worker, and this fits perfectly because office workers often do repetitive hand movements like typing, writing and using a mouse. This repetitive action can cause the inflammation of the tendon inside the carpal tunnel. When these tendons become swollen and fluid builds up, and that increased the pressure inside the carpal tunnel and compressed the median nerve. As a result, the patient experienced numbness and tingling in the lateral 3.5 of the fingers, and this condition is called carpal tunnel syndrome. And it's not only the office worker who can develop the carpal tunnel syndrome, it can also happen in pregnant women because of fluid retention and patient with rheumatoid arthritis due to joint inflammation. In these cases, the mechanism is the same, that is increased pressure inside the carpal tunnel and compressed the median nerve. If we see once the median nerve enter in the palm below the flexor retinaculum, it divides into medial and lateral branches. From this, it gives muscular tweaks to first and second lumbricals. It also subdivided into the proper digital nerves, which supply the skin of the palmar side of the lateral 3.5 fingers. But here's something important. Before entering the carpal tunnel, the median nerve gives off a branch which is called palmar cutaneous nerve. Unlike the main trunk, this nerve does not pass through the carpal tunnel. Instead, it travels superficially over the top of flexor retinaculum and supplies sensation in the center of the palm and thinner side of the palm. Because of its unique course, the palmar cutaneous nerve is usually spared in carpal tunnel syndrome. That's why the patient reports numbness in their thumb, index and middle finger and half of the ring finger, but retain normal sensation in the center and lateral side of the palm. Now let's come to the third clue. The patient is having difficulty in holding a small object. To understand that, we have to go back to the course of the median nerve in the hand. Inside the carpal tunnel, before dividing into medial and lateral branches. The median nerve gives off a branch which is named recurrent muscular branch. This branch supplies the three thenar muscles. They are named flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis. Together, these muscles are overlap and their function overlaps too. Together, these three muscles produce abduction and flexion at the carpometacarpal joint, and these movements add up to opposition of the thumb. And the opposition of the thumb is required for many daily activities like picking the small objects, buttoning the shirt, and grasping a pen. So when the median nerve is compressed in the carpal tunnel syndrome, these muscles become weak. As a result, opposition of the thumb is impaired and making it difficult to perform fine tasks, and that is exactly what we see in the patient from our scenario. Now let's answer the key question. The first question is, which nerve is being compressed in this condition? The answer is median nerve, as it passes through the carpal tunnel. And second question is, why there is weakness in thumb opposition? The thumb opposition is mainly caused by the opponens pollicis, but the flexor pollicis brevis and abductor pollicis brevis, they also help in this action, and these are three thenar muscles which are supplied by the recurrent branch of median nerve. And when median nerve is compressed, this branch also affected and leading to weakness in the thumb opposition. Our third question is, explain anatomically why the skin over the central and thinner side of the palm is not affected. Because median nerve, before entering the carpal tunnel, it gives a palmar cutaneous branch. This branch travels above the flexor retinaculum and supplies sensation to the central palm and thinner eminence. Because it does not passes through the carpal tunnel and it is spared in compression. That's why the sensation of this part of the palm remain normal. This brings us the end of this case, and if you found this video helpful, don't forget to like, share, and subscribe my channel for more anatomy and clinical cases discussion. Thank you all.